Good morning, everyone. At the outset, I thank Dr. Rajesh sir and his team for giving me this opportunity to speak on astigmatism, how to give best results. I have no financial interest to disclose. If you see the cataract patients who are coming for surgery, almost 22% of your patient will have astigmatism of exceeding 1.5 diopter. And if you see the clinical significant astigmatism, which is around more than 1 diopter. Now, how do we correct this astigmatism? There are various ways to correct astigmatism. Spectacular contact lenses, which may be given post-operatively. Excimer laser, which can be used if you have some amount of post-op astigmatism by LASIK or PRK. Incisional corneal surgery, that is LRI, or astigmatic keratectomy at the time of the surgery, but they have their inherent problems. So the best way to correct astigmatism is by toric IOL, which can be corrected on the table itself, and the amount of astigmatism which you can correct is variable. It varies from 0.75 to maybe around 5 to 6 diopter. But the patient selection is very important. Patient should have a primary corneal type of astigmatism, not the lenticular or other type of astigmatism. It should be regular bow tie type of astigmatism. Keratoconus with no or negligible progression. There should not be any progression in keratoconus. Post keratoplasty, eyes only with mild to moderate amount of astigmatism. Patients with corneal pathology like Fuchs endothelial dystrophy or stomal dystrophy, they are not ideal for correction of astigmatism by toric lenses. Patients with potential capsular bag instability, that is pseudoexpolation or zonular dehiscence, they are not contraindicated for putting toric IOL intraoperatively. So we have seen the indications and amount of astigmatism which you can correct. Now, what is different you can do intraoperatively? The accurate keratometry, that is very important. Reference and axis marking, that is different from your routine cataract surgery. And aligning of the IOL, which is very important. I will be dealing with this aligning of the IOL, because that is the most important step while you align the toric IOL, removal of complete OVD and the typing of the IOL. So we will see these 4 things one by one. Accurate keratometry readings, it should be comparable, consistent and repeatable. My choice of measuring the corneal dioptric power is by optical biometer. And if you have any doubt about the readings, you can perform topography. When you should repeat the keratometry, if you have K reading of less than 40 diopter or more than 47 diopter, because they suggest that if you have a less than 40 diopter of the astigmatism, that or keratometry reading, that suggests that the patient had previously undergone keratorefractive surgery. If it is more than 47 diopter, it suggests that some amount of keratoconus, so you have to cautiously deal with these patients. If you have calculated the keratometric reading on your spectacle correction that is not correlating with your optical biometer readings, you should again check with other methods. Difference in keratometric value between 2 eyes, that is if you have a difference of 1 to 1.5 diopter in between 2 eyes, which is not correlating, so you should repeat the keratometry readings. Reference marking, there are various ways to mark the axis. These are the various markers which are there. And I'm not using any one of these because I had bubble marker, but because of ignorance of my staff, they put it in autoclave, and so it's no more available for measurement or marking of the axis. So the one which I use, which is suitable for measurement, is by reference marking on the slit lamp. You have everyone has slit lamp, and it has got an axis which you it has got a slit beam which you can rotate horizontally as well as vertically as well as obliquely. So that is the best thing I think which you can do on the slit lamp. 0 to 180 degree or 90 degree you can mark on the slit lamp, and you can either mark with the help of your Jensen violet ink marker or with the help of 26 gauge needle. But 26 gauge needle puts permanent mark on the cornea, and that may give some amount of discomfort post-operatively. Maybe it will take around 24 to 48 hours to fade these marks. Now, limitations of manual marking, error of 2 to 10 degree, which is expected. Marks may fade or spread if you before you take the patient for the surgery. Difficult to see these marks intraoperatively. Image guided systems are devised, but they are costly, and I don't have any experience about this image guided system. As far as IOL power calculation is concerned, totally rely on either optical biometer or on immersion, no contact method I perform nowadays. Intraoperative steps, incision should be placed at an intended axis, that is corneal or scleral. The perfect CCC in the tune of 5.5 millimeter, that is essential, so that there won't be any rotation of the IOL. No posterior capsular rent. If you have a posterior capsular rent, defer putting any type of premium IOL. May it be multifocal or toric IOL. Perfect cortical cleanup and perfect viscoelastic removal, that is very important. Now, if you see the alignment of these toric markers, every 1 degree of misalignment gives to 3.3% variability in the cylindrical power, and that is lost. So for 10 degree, there is 33% of the lost, and misalignment of 30 degree of IOL will lose entire cylindrical power. If you see the toric marks on the IOL marks on the toric IOL represent the flat curvature of the IOL to be matched on the steep meridian of the cornea. So you have to consider the steep meridian for placing this toric marks on the IOL. These are the various markers which you can place on the cornea for the placement of toric IOL. On the left side, you can see the marks which are there, and these are from 0 to 180 degree. And on the right side, you see the marker which you have to place on the intended axis to be placed while performing the placement of toric IOL. Now I will be showing this video of placement of the toric IOL inside. Once you have completed the cataract surgery, you can see I have placed marks on the toric IOL which is around 20 degree away from the intended axis on the cornea to be placed. I am clearing the viscoelastic thoroughly from the anterior chamber with the help of bimanual irrigation and aspiration. You can use whatever irrigation aspiration method you are following, maybe a coaxial or with the help of Simcoe's cannula, but I prefer this eye method because you can go behind the IOL and clean up the viscoelastic very properly. This cleaning of viscoelastic from behind the IOL is important because it can cause rotation of the IOL post-operatively. So place the irrigating cannula above the IOL and with the help of aspiration, you may not aspirate, just keep it behind the IOL and wash the viscoelastic. You can reverse the way you want. There may be refractive surprises after toric IOL. There are various reasons for it, and you can fix up this misalignment with the help of astigmaticfix.com, which is available on the ascrs.com. So take-home message is astigmatism correction with the toric IOL is more safe, effective, and stable, and which is predictable. And you should have accurate keratometry, reference marking, and accurate alignment. That is very important. Complete overlap of the optic axis by CCC and complete removal of the viscoelastic. That is the most important part. Thanks for your patience listening.
Thank you, Rajesh, for nice presentation on astigmatism